So this is a lecture for cardiovascular pathology. This lecture is not meant to replace an in-depth review of the specialty of cardiovascular pathology, but more on academic review. Basically, the lecture outline consists of pathology, heart failure. We will discuss the left and the right, the heart diseases, which include your congenital heart. Briefly, I will discuss the left and the right shunts, the right and the left shunts and obstructive. We have the ischemic, hypertensive, valvular, cardiomyopathy, pericardium, tumors, very brief on transplantation and myocardial injury associated with COVID-19. So what are the normal features of the heart? The heart pumps approximately 6,000 liters a day of blood, and in the Caucasian population, the heart weighs 250 to 300 grams, and at least 40% of all deaths are associated with malfunctions of the cardiovascular system. Well, primarily, the wall thickness is also correlated with the pressure, and obviously a wall can only be as thick as it has to be, except in hypertrophic cardiomyopathy, which can be exaggerated. So your normal LV is about 1.5 centimeter, your RV is about 0.5 centimeter, and the atria is about 0.2 centimeter in thickness. So let's first discuss the terms. So cardiomegaly, when we say cardiomegaly, it means a dilatation or a hypertrophy. So a dilatation can be in any chamber or all, and hypertrophy is also any chamber or all. So in the pathophysiology of these conditions, the dilatations or hypertrophy would usually start in the left ventricle. So usually the first changes or the first change would be hypertrophy of the left ventricle, but eventually it will spread to the LA, RV, and then to RA. And in the end stage, for example, of heart failure, the heart will become dilated, which again start in LV, LA, and then RV and to LA. But in the clinical setting, most of the time, we see hypertrophy or dilatations in almost all chambers of the heart. So this is a comparison between hypertrophy and dilatation. So you can see here the heart, specifically the LV, is widely dilated, and this one here is again an LV with a hypertrophic wall. So basically, in autopsy, we can say that the particular chamber is hypertrophic by measuring the thickness of the free wall of the LV. Now, in pathological heart remodeling, we can see here the normal heart or the heart in its normal conditions on the left side. But during pathological heart remodeling, there are changes which can be a dilatation or hypertrophy. In general, the heart would start first as hypertrophic and on the later stage will become dilated. So during the dilatation stage, it is also called eccentric hypertrophy. The myocardial cells are added in series or in sequence. While initially, during the hypertrophic phase, the myocardial cells are added in parallel, causing the hypertrophic changes. But of course, this is not a general rule that the sequence would be a hypertrophy and dilatation, such as in cardiomyopathy, when the heart would simply become dilated, and hypertrophic, when the heart would simply become hypertrophic. So just to emphasize that a dilatation of the heart, the myocardial cells are in series, while in hypertrophy, the myocardial cells are in parallel. So a brief review of the histology of the heart. So you have your striations. You can see the nuclei, the intercalated disc, your sarcolemma, your sarcoplasmic reticulum, the mitochondria, the endothelium, the fibroblasts, and your collagen. Now we can see here the sequence also, or rather the different conducting systems of the heart. We have the SA node, AV node, the bundle of His, and we have the left bundle branch and the right bundle branch. So we always think that the conducting system of the heart is a muscle or a nervous or part of the nervous system, but basically this is a modified tissue with characteristic about the muscles and the nervous system or the nerve. Now briefly showing also the anatomic distribution of the vasculature of the heart. So take note in this part, along the posterior descending artery and the diagonal branch of left anterior descending artery, that's where the location of the most or the most common location of your myocardial infarctions, because this is one of the least perfused areas of the heart. Again, it's also important to know the different annular circumference of the valve, but this is again from the Caucasian population. A tricuspid measures about 13 centimeter, a mitral is about 11, the semilunar is pulmonic about 8 centimeter, and the aortic is 6 centimeter. So this is a cut open measurement of the valve or annular circumference. Now let's go to the histology of the cardiac valves. So we often encounter valves in our setting, but we rarely discuss the histology of the valve in details. So the valve has three layers. We have the ventricularis, which is located in the ventricular side, the spongiosal layer or in the middle, and of course at the aortic side would be your the fibrosa layer. Take note that in fibromyxoid chains, it's the spongiosal layer that is thickened, making the valve redundant, and this can be best demonstrated if we do an elastic sting. Also take note that on each sides of the valves there's a single lining of your endothelial cells, both in the aortic side and in the ventricular side. And also in the stroma you have the interstitial cells. So the interstitial cells actually functions like stem cells. They can differentiate into bone, cartilage, and any other tissue. That's why you can see cartilaginous and chondroid metaplasia in the valve. Also, they can be converted into an adipose tissue, and thus explains the adipose metaplasia in the valve. So what are the features of an old heart or cardiac aging? So in the chamber, there's an increase in left atrial cavity size, decreased left ventricular cavity size as well, a sigmoid-shaped ventricular septum. In the valves, you have aortic valve calcific deposits, mitral valve annular calcific deposits, fibrous thickening of the leaflets, and buckling of mitral leaflets toward the left atrium. The epicardial coronary arteries would show tortuosity, increased cross-sectional luminal area, calcific deposits, and atherosclerotic plaque. Actually, the changes in the epicardial coronary arteries are not exactly normal, but they are so common in most people that they are seen as quote-unquote normal. In the myocardium, there will be an increase in the mass. Also, there will be an increase in subepicardial fat. And histologically, we can see the brown atrophy, the lipofuscin deposition, with basophilic degenerations and sometimes amyloid deposits. So the amyloid deposits has to be only focal for it to consider to be normal features of cardiac aging. So this is again a composite photo of the heart. This is a four-chamber view here, a normal heart, and then you can see here a hypertrophic heart, a normal heart, and a dilated heart. So in congestive heart failure, the autopsy findings usually are cardiomegaly, which is where we use the weight of the heart as the basis to say that it's cardiomegaly. Of course, you can see chamber dilatation, but the dilatation only happened on the very, very late stage of this CHF. And initially, the changes would be hypertrophy of the myocardial fiber, where we can describe this as a boxcar nuclei. So this is a boxcar comparison. So we always see this in specimen in our setting. Sometimes our valve specimen has an attached myocardium. So this is a boxcar, or you can see there's an enlargement and squaring of the individual nuclei. Now let's go to the different methods in cardiac dissection. So in the slides, we only mentioned about 8. We have the inflow and outflow method. We have the short axis method. We have the four-chamber method, the long axis method, the base of heart method, the window method, and the last two, the unrolling method and partition method, will not be discussed here. So basically, we will discuss only the first 6 method of cardiac dissections. The other methods are not mentioned here because they are very specific and probably used only for research. The first 4 methods are useful for demonstrating cardiac pathology, while base of the heart and window method are for anatomic teaching and museum specimen demonstration and preparation. In the inflow and outflow method, although this is best demonstrated, of course, in actual heart dissection, by using sharp scissors, you made the initial cut from the inferior vena cava to the right atrial appendage, sparing your SVC and SA node. So the right ventricle is then opened with knife along 1 centimeter parallel to the posterior ventricular septum, and then the outflow tract is open at 1 centimeter parallel to the anterior ventricular septum. In the left side, you start opening your left atrium between the right and the left pulmonary veins, cutting through it, and then the left atrial appendage is checked for mural thrombus. The inflow tract from the left ventricle is opened along its inferolateral border, while the outflow tract, to avoid damage to the mitral valve, you have to open it 1 centimeter parallel to the anterior ventricular septal groove. So this is like, in essence, you open the heart like as following the Z letter, from starting from the right atrium to the right ventricle, then to the left atrium, and then into the left ventricle. Now this is an actual heart which I opened during a workshop in the Philippine Heart Center many years ago. So we are facing, or we are looking at the anterior surface of the heart. So just following the instructions from the previous slide. So this is the RA part here. So it just open on one side all the way into the RV. So we have now a partially opened heart, and then from the level of between RA and RV, we open now the pulmonary artery all the way through it, and then from the left side, we open from the from the LA to LV, and then following the course of the aorta, we open it uh, all the way into the uh, LV. So I think it's really best to see this on with actual demonstration. So the first method is the inflow and outflow method. This is probably the best method because you can use this to demonstrate different lesions, whether it's congenital heart, even ischemic heart disease, or cardiomyopathies. So this is actually the default method. So if you're not sure, sometimes we don't know what are the lesions of the heart, we can always follow the inflow and outflow method, and that is basically how you dissect the heart from the previous slides. So opening it from the RA and then to RV and then the pulmonary artery and then into the LA and LV and into the aorta. The short axis method is commonly used for ischemic heart disease like myocardial infarction. So this is your bread loafing method because this can demonstrate the greatest area of the heart, of the wall of the heart. So you can see here a hypertrophic heart demonstrating the greatest area. So you start slicing it from basically from the apex into the base, and you can demonstrate and you can differentiate whether the MI is or the extent of the ischemia in the MI. So here you can see some areas of infarctions using this method. The next method is the four-chamber method. So this is basically like the coronal sectioning of the heart. This would best demonstrate or best used to demonstrate congenital heart disease. For example, like the transposition of the great arteries. So you can see that the pulmonary artery arises from the left ventricles and the aorta from the right ventricles. So basically for congenital heart diseases and also valve diseases. In the long axis method, maybe the comparison here is the sagittal section. This is also used to demonstrate some congenital heart disease as well as valvular heart diseases. And then we have the base of the heart, also similar to the first, to the last two rather, which you can also demonstrate the especially defects in the heart or in the valves from congenital heart diseases or probably from infections or other cardiomyopathies. And the window method is you just simply open portion of the heart to demonstrate the specific changes or specific pathology. Like this is PDA, and this is best to demonstrate lesions for museum or for research purposes. Now, what are the guidelines in the for autopsy investigation of sudden cardiac death? So the Association for European Cardiovascular Pathology published this in 2017. So when we say sudden cardiac death, these are um, deaths that cannot be accounted with specific diseases. But of course, the most common clinical findings would be the presence of possible arrhythmia. And in general, after autopsy, most cases are due to ischemic heart diseases as well, possibly MI or atherosclerosis. So how do you dissect the heart with this one? So the guidelines basically is you have to check the left coronary arteries and right coronary arteries for the patency. And then you have to dissect that entire stretch of coronary arteries at this slices. I think this is about zero point 0.1 or 0.2 centimeter. So all the way through it. So The link for this article is written in the succeeding slides. So once the coronary arteries are dissected and sliced through, you can do the bread loafing of the heart, and you can now demonstrate the extent of the MI through this method of heart dissection. Now there are questions about how many samples would you submit. In our setting, because we have a limited resources, we submit maybe 4 or 5 cut from a particular section. But in this guidelines, the 2017 guidelines, you have to submit at least 10 section. Yes, 10 sections here based on this slices. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And of course, your coronary arteries, which you have to submit everything. So you can check in the details through this link here. How about the dissection of your conducting system of the heart? So in general, this is very difficult to do because there are no specific appearance or gross morphology that what you are cutting through is a conducting system of the heart. It is always an estimate, so you will sample a lot in a particular area. So in general, we are really eyeballing during the sampling of the cardiac conduction system. So the rule basically is if the cause of the death is far from arrhythmia, we prefer not to sample the conducting system of the heart. So our next topic would be the congenital heart diseases. So congenital heart diseases or defects results from faulty embryogenesis at week 3 to week 8. It is usually monomorphic, meaning there's a single lesions, like an ASD, a VSD, a hypoplastic RV, or a hypoplastic LV. Now, there are also cases that they may not be evident until adult life, such as your coarctation of aorta and ASD. And that's why at the Philippine Heart Center, we have now a center called Adult Congenital Heart Diseases. In the US, the overall incidence is 1%, and I think it is higher in the Philippines because according to statistics, the prevalence of congenital heart disease at birth is about 5 per 1,000 live births, and this is about 2 years ago. Now, there is also an increase in the detection of this condition because of improved non-invasive methods such as your ultrasound, MRI, and CT scan. So in general, the most common is your ventricular septal defects, and followed by ASD, your pulmonary stenosis, and patent ductus arteriosus. So in this graph, you can see that all T are right to left, the trilogy of Fallot, transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous connection, and tricuspid atresia. The genetic abnormalities is seen in about 10% only of congenital heart diseases and common in trisomies just 21, 13, 15, 18. Also, the environmental factors should be considered like exposure to rubella and other teratogens. So in med school, we know that the left to right shunts, usually they have all these in their names, so there is no cyanosis, but the most dreaded condition here is the development of pulmonary hypertension, specifically the irreversible pulmonary hypertension. Your right to left shunts, which are all T's in general, would manifest with cyanosis, and these are your blue babies. They could also develop your venous emboli, and they become systemic, and and this is what they call a paradoxical emboli. The third group of congenital heart disease is your obstruction, which can be your aorta, like coarctation of aorta, or pulmonary artery. So left to right shunt. So your left to right shunt has or are non-cyanotic, but the most dreaded condition again is your irreversible pulmonary hypertension, usually if it led to stage 3. So these are your left to right shunt again, your ASD, VSD, PDA, complete atrioventricular canal defect, and even large VSD. So your ASD is different from your patent foramen ovale. So this is obviously, as the name implies, there's a defect in your atrial septum. It is usually asymptomatic until adulthood and is one of the most common adult congenital heart diseases. So it can be a secundum, primum, or sinus venosus, depending on the location of the defects. So you can see here the atrial septal defects. So in general, if we have to define this, an atrial septal defect is a hole in the interatrial septum or the wall dividing the two atria. It is a congenital heart defect, so oxygenated blood flows through the hole from the left to right atrium instead of the left ventricle. So again, the flow is left to right because the pressure in the right side of the heart is greater than into the right. So again, this is based on the location of the defects. So we have the primum, the sinus venosus, and the secundum. Next one is the VSD, which is the most common. So only 30% are isolated. Majority are often in association with your tetralogy of Fallot. And 90% involve the membranous septum, which you will show later. If muscular septum is involved, it's likely to have multiple holes. So in general, the small one often closes spontaneously, but the large one progresses to pulmonary hypertension, and also this can also lead to one of those common adult congenital heart diseases. So this is your VSD, a defects in the interventricular septum. So you can see here there's the mixture of the blood because the blood can flow from the right side of the, or rather from the left side of the ventricle to the right side or right ventricle because again of the difference in the pressure. So again, based on the location here, next one is the patent ductus arteriosus. Again, 90% are isolated. The characteristic murmur here is described as machinery-like murmur or harsh murmur. So this is generally a left to right congenital heart diseases, but it can possibly become a right to left defects as the pulmonary hypertension approaches the systemic pressure. So it is important that the closing defects may be life-saving. At the Philippine Heart Center, smaller defects are treated with prostaglandin E1, but eventually if the defects is so large, then surgical intervention may be necessary. So again, this is your schematic representation of your patent ductus arteriosus. Also, schematic representation of your patent ductus arteriosus, showing the blood flow here. Less common congenital heart diseases are your AVSD, which is associated with defective, inadequate AV valves. It can be partial or complete. So basically, with these defects, we can say that all four chambers freely communicate with one another. Now let's go to the right to left shunt. So all T except the Eisenmenger syndrome. So tetralogy of Fallot, transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous connection, tricuspid atresia, and the Eisenmenger syndrome. So in general, this is not in the terms of congenital heart disease autopsy. These lesions are not uncommon. So a few years ago, we have seen a lot of these cases, especially with pediatric autopsies. So we have the right to left shunts. The tetralogy of Fallot is the most common and consists of 4 components. We have the large VSD, a pulmonary artery stenosis or pulmonary valve stenosis. So there's an obstruction to the RV flow. Aorta overrides the VSD. So what does it mean by overriding of the aorta? It means that the aorta is closer to the interventricular septum rather than into the left ventricle. And then the fourth component is your right ventricular hypertrophy. Take note that the survival depends on the severity of the subpulmonic stenosis. So this can be a pink tetralogy if the pulmonic obstruction is small, but the greater the obstruction, the greater is the right to left shunt, or your typical cyanotic congenital heart disease. So this is schematic representation of your TOF. Again, another representation of your TOF showing the blood flow here. So you consider a mixture of blood originating actually in the large VSD. Other right to left shunts is the TGA, or the transposition of great arteries or great vessels. So you need a shunt here for the survival, obviously, and that is your PDA, or it can also be your patent foramen ovale in 65% of cases. You also have a VSD here. The RV here is greater than LV in thickness. So obviously here with the TGA, there's a switching. The pulmonary artery arises in the left ventricle, while the aorta is from the right ventricles. So it is basically fatal in the first few months. So it's important that a surgical switching intervention should be done. Next is your truncus arteriosus. So when we say truncus arteriosus, the trunk fails to divide into aorta and pulmonary arteries, so you only have one single vessels in the heart. Next is the tricuspid atresia. Of course, that is narrowing of your tricuspid valve. This is an association also with the hypoplastic right ventricle. So you need a shunt, which can be an ASD, a VSD, or a PDA. It's a very high mortality. And then you have the total anomalous pulmonary venous connection, or pulmonary venous return, TOP VR or TOP VC. So the main pathology here is that the pulmonary veins do not go into LA but into the left innominate vein or the coronary sinus. So the shunt provided here would be a PFO or sometimes a VSD. And you have a hypoplastic left atrium as a result of this morphologic abnormalities. And then the third group of congenital heart diseases is your obstructive, and the most common of which is the coarctation of the aorta, but also pulmonary stenosis or atresia, or aortic stenosis or atresia. So in coarctation of aorta, we have an infantile form when the coarctation is proximal to the PDA, which is more serious, or an adult form, which is a closed ductus, so there's no need for PDA here. This is also an association with bicuspid aortic valve in 50% of the cases, which in turn, if the patient survived to the adulthood, this is also prone to a lot of stenosis of the aortic valve. Then you have the pulmonic stenosis or atresia. If 100% atretic, you will have a hypoplastic RV with ASD, and in general, the clinical severity correlates with with the severity of the stenosis. And of course, you have your aortic stenosis or atresia. It can be valvular, subvalvular, or supravalvular, depending on the location. Our next topic is the ischemic heart diseases. So the syndromes of ischemic heart diseases is more of internal medicine topic than pathology, but nevertheless we will discuss this in summary. So we have angina pectoris, which can be stable or unstable. Eventually, your IHD is correlated with your myocardial infarction. So if you have chronic ischemic heart disease and you don't develop myocardial infarctions, more likely the endpoint will be your congestive heart failure, and you can also develop sudden cardiac death. Your ischemic heart disease is related to your atherosclerosis or plaque formation. So it depends on the number of plaques present in the involved vessels, the distribution of plaques, the size and structure of plaques. In acute coronary syndrome, it is defined as frequently initiated by an unpredictable and abrupt conversion of a stable atherosclerotic plaque to an unstable and potentially life-threatening atherothrombotic lesion through superficial erosion, ulceration, fissuring, rupture, or deep hemorrhage, usually with superimposed thrombosis. So in general, in acute coronary syndrome, you have an atherosclerosis in an involved vessels, and the narrowing for it to be significant is about 75% or greater. However, a lesser percentage of narrowing can still cause ischemia if the plaque is become unstable and traps some of the blood clot passing through as the blood flows into the lumen, and that causes the blockage to up to 95% or even 100%, causing the ischemia. About 500,000 die of IHD yearly in the US, but this is in the 1960s. Probably this is tripled nowadays, and 90% of the patient have atherosclerosis. So most important is the acute plaque change. It is said that the plaque itself is a very unstable structure. It is like a volcano. So inside it contains usually the cholesterol crystals, but they are actually a high energy component, and that can actually be disrupted or dislodged at some point or at any point, depending on the hemodynamics involved. There's also the factor of inflammation, of course, the thrombose formation and vasoconstriction of the blood vessels, which can make the plaque unstable. So the events would lead to, let's say, a rupture or refissuring, leading to erosion or ulcerations of the blood vessels involved, leading to acute hemorrhage. So take note that plaques do not have to be severely stenotic to cause acute changes. 50% of AMI results from a thrombosis of plaque showing less than 50% stenosis. Although in theory, the significant blockage is about 75%, but clinically, most plaques that causing ischemia shows only 50% narrowing. So this is just to show you a plaque. This is only about 50% narrowing, but with the presence of sudden thrombosis, it can block the entire lumen up to 100%. As in here also, a very unstable plaque with multiple lumen at the various sites. So very important is the disruption of your plaque, which can lead to thrombosis, because the thrombus can cause total occlusions, partial occlusions, or the thrombus can actually emboli to other parts of the blood vessels, which are narrower and can cause total obstruction. So again, we can see here the pathogenesis of your plaque formations leading to occlusive thrombosis. So we have two types of myocardial infarction. We have transmural or subendocardial, meaning the inner one-third only. They have exact similar risk factor as atherosclerosis. But most of the myocardial infarctions are actually transmural, and most are caused by coronary artery occlusions. But I say most here because drug intake can also cause myocardial infarctions without the necessary physical coronary artery occlusions. So let's say in the 10% of the transmural MI, which is not associated with atherosclerosis, the etiology can be vasospasm and emboli, and then explains just drug intake. So a very favorite question is the myocardial response. At the histologic level, there is an onset of ATP depletions few seconds after the blockage of the area of ischemia. And there's a continuous more than 2-minute blockage would result in the loss of contractility. ATP is already reduced at 10 minutes, and 10% of normal is the remaining functions by about 40 minutes. Irreversible cell changes happen after 20 to 40 minutes of continuous ischemia, and microvascular injury occurs if the blockage is not corrected after more than an hour. So take note, I mentioned earlier the zone of perfusion here, which is our area of risk, because this is already poorly perfused areas because of the distribution of the vasculature. So you can see here the completed infarct involving the entire area of risk, and there's a progression here, the endocardium, featuring the zone of perfusion at risk, and changes is already evident about the second hour, but this is only seen in the microscopic analysis, and the zone of necrosis can spread after 24 hours. So in the olden times, you can use TTC, staining of myocardium, but this is said to be a very carcinogenic substance. And what you do here is you submerge the entire, you can cut the heart basically in the short axis, but since there are no changes during the first 4 hours, you cannot exactly say the presence of myocardial infarctions. But putting the entire structures or submerge them, cut a portion of this or a slice of the heart in a TTC, and then that you can see here some changes. There's whitish discolorations in the area, and then you can see, so we can see the morphologic changes even if the infarction occurs by less than 4 hours. So this is a well-preserved heart. You can see here the area of ischemia, the whitish area here. So we also encounter patients who have no symptoms at all in the past, but suddenly died of MI because we have what we call the silent MI. If they are just focal, so it won't cause significant clinical symptoms, but over time, with repeated ischemia, the different parts of the coronaries that can cause the symptoms in the end, and basically it would lead to arrhythmia or other complications of the MI. So this is our old MI, subacute or days old MI, and healed. It can lead to weeks to year-old MI. Again, in histology, you can see here the areas of infarctions. So this is already the stage of fibrosis, effacing the myocardium involved. Again, this is from your book, The Timing of Gross and Microscopic Findings. So as mentioned earlier, if the changes is less than 4 hours, there are none. And there is occasional mottling, dark mottling by 12 to 24 hours. And of course, it progresses into yellow, hyperemic border, and scarring is complete by 2 months. And take note the corresponding microscopic changes. So in 1 to 3 days, you have coagulation necrosis. 3 to 7 days, we have neutrophils. 7 days, we have phagocytosis and granulation tissue formation. And about 2 weeks, you have already the well-established granulation tissue. And by 8 weeks, you have your scarring, increased collagen deposition. More than 2 months, very obvious dense collagenous scarring. So again, in summary, we have here 1 day pycnosis or weaviness, 3 to 4 days infiltration of neutrophils, 7 days lymphocytes and macrophages, about weeks or an organization, granulation tissue formation, about 2 months, there's a fibrosis. Now, the current treatment of myocardial infarction is to reperfuse the area of injury by thrombolytic agents, also from percutaneous or PTCA or a cabbage. So reperfusion actually cannot restore necrotic or dead fibers, but only the reversibly injured one or those less than 4 hours or 40 minutes of injury to prevent further necrosis. So, and that's why you also develop the so-called reperfusion injury because of the hypercontractions of your myocardial fibers. So the ischemia basically release free radicals, and when the area of ischemia is suddenly given free or full blood flow, it can release a lot of free radicals, causing injury in the ischemic portion of the heart. And this is the manifestation. This is called contraction band necrosis. So this is a marker of reperfusion injury because of the reperfusion intervention. So this looks like actually like intercalated disc, but hypereosinophilic lining that tends to divide the myocardium. So we know this already, the AMI diagnosis, you need 3, right? The symptoms, ECG, and of course the enzyme, elevated enzyme. So you have also diaphoresis. Take note that 10% of MI are silent. So before you can use CKMB, but the College of American Cardiology prefers the use of troponin I and troponin T to better predict or to better in the assessment of your AMI. So what are the complications of MI, which is actually, this is the cause of death of the MI. So we can have wall motion abnormalities, arrhythmia, which is very common, probably one of the most common causes of your mortality. It can also rupture your free wall in 4 to 5 days here. A pericarditis can also occur. A right ventricular infarctions, extension of your infarctions, presence of mural thrombi, a ventricular aneurysm. So this is also like the thinning of the wall of the left ventricle, but not to the point of rupture. But the MI can also cause papillary muscle dysfunctions. And of course, congestive heart failure. So ischemic cardiomyopathy is a different term used or used to describe your ischemic heart disease. So again, as I mentioned earlier, more than 75% of stenosis in the left main stem or left anterior descending artery is the threshold to cause ischemia. This is in theory, but clinically, as I mentioned earlier, they found out that even 50% can cause clinical manifestation already. So what is the definition of your sudden cardiac death? It is defined as a death generally within less than 1 hour from the onset of symptoms. So the most common presentation basically is the presence of arrhythmia, so highly associated with your atherosclerosis. But other non-atherosclerotic etiologies are your congenital coronary artery disease, aortic stenosis, myocarditis, cardiomyopathy, especially hypertrophic cardiomyopathy, pulmonary hypertension, conduction defects, and other unknown etiologies. There is 75% narrowing of 1 to 3 vessels, and it is said that patients already have a healed infarcts in 40% of cases. So arrhythmia is often a very convenient conclusion when no anatomic findings are present, but without an autopsy, we won't know if the patient actually have a lot of atherosclerosis in the different vessels. Now let's go to the hypertensive heart disease. So the definition of hypertensive heart disease is that hypertrophic adaptive response of the heart can progress into myocardial dysfunction, cardiac dilatation, congestive heart failure, or sudden death. So again, this is a hypertrophic heart and this is a dilated heart. Both can be due to hypertensive heart disease because initially the response of the heart in increased pressure is thickening of the wall. So there is an hypertrophy, especially of the left ventricular wall. But in the end, the, the hypertrophy can spread into the left atrium, to the right ventricle, and to the right atrium. But over time, the morphologic changes would be dilatations, which is dilatation initially of your left ventricle again, and then left atrium, right ventricle, and right atriums, overall with an extensively dilated heart. In hypertrophic changes, there's an increase in the fiber thickness. So you can see here an enlargement and squaring of the individual nuclei. And as a review, the myocardial cells here are added in sequence or in series, causing the hypertrophic changes. Let's go to the valvular heart diseases. So this is not a dogmatic association, but an opening problem is usually due to stenosis, while a closing problem is usually due to regurgitation. Now, 70% of all VHD in the US are due to aortic stenosis, which can be due to calcification of the deformed valve from aging. It can be from the other condition like rheumatic heart diseases. But in the Philippines, the most common cause is mitral stenosis from rheumatic heart diseases. So you can see here, so since we're using the textbook from the US, the aortic stenosis would of course shows here some decrease in the lumen, and we can see here a lot of calcifications causing the non-pliable movement or restricted movement of your valves. In mitral annular calcification, you can also see calcifications of the mitral skeleton from the X-ray itself here. And of course, you have the regurgitations. In aortic regurgitations, it is also again due, the most common etiologies are rheumatic. It can be infectious or aortic dilatation. And then we have the mitral valve prolapse, which can be due to your infectious, again, rheumatic heart disease, because some of the endpoint morphologic changes of RHD can also be mitral valve prolapse. We have the fen, which is a drugs used before for reduction of weight, papillary muscles, chordate and calcification of the mitral ring. Now, in mitral valve prolapse, again, specifically, this is the myxomatous degeneration of the mitral valve associated with connective tissue disorders, which is one of the most common is your Marfan syndrome, but can also be in Ehlers-Danlos syndrome. So this is described as a floppy mitral valve because the valve has a texture of a gelatin instead of being fibrous. It has a higher incidence in female than in male, and it can easily be diagnosed into the echo. It can be asymptomatic, but if very progressive, you can you can diagnose this with a mid-systolic click. Patient can present with occasional chest pain, dyspnea, and 3% is can lead to infective endocarditis, mitral valve insufficiency, arrhythmia, or sudden death. So it is said that in some institutions, patients presenting with some Marfan-like syndrome or Marfanoid-like syndromes are advised to have a 2D echo. So you can see here a tall, thin build, flexible joint, presence of scoliosis, increased risk of pneumothorax, long fingers, webbed neck. So that's the advice basically for patient with this if some of the presentations are present in the patient. So the fluffy mitral valve here, it is a gelatinous um, redundant structure. Microscopically, as I mentioned in the earlier slide, there's a thickening of the spongiosal layer with deposition of your mucoid or myxomatous materials, which can be best demonstrated by your elastic stain. Next, rheumatic heart disease. It follows a group A strep infections a few weeks later, but this is well decreased in developed countries. And you also have your pancarditis, meaning the inflammation actually occurs in all layers of the heart: endocarditis, myocarditis, and pericarditis. So during the acute rheumatic heart fever, there's of course an active inflammation, and there's a presence of Aschoff bodies here. So the Aschoff bodies or Aschoff bodies are just these are histiocytes, and they forms a granuloma appearance. These are just macrophages or histiocytes conglomerate together with some inflammatory cells around. And then some of these histiocytes can assume the morphology of your caterpillar, which is called Anichko cells or caterpillar cells. The inflammation occurs across all layers: endocarditis or endocardium, myocardium, and pericardium. And you can also develop vegetations on the chordae tendineae, the leaflet, or the verruca. Now the chronic, so basically in the acute inflammation is not uncommon anymore because patients are usually given antibiotics. So these findings are present in the past when patients died of acute episodes of rheumatic heart disease. Now, what we commonly see now are the chronic heart disease or chronic rheumatic heart disease, featuring your thickened valves, fusion of the commissures, and we have the thick, short chordae tendineae. So this is your Ashkoff bodies here. These are collections of your histiocytes, and some of which assume a caterpillar appearance called Anichko cells. Again, the description for the valve involved is a fish buttonhole or fish mouth orifice, narrowed because of the effects of fibrosis due to chronic inflammation. So you can see here the progress of the inflammation. This is your aortic valve. This is your mitral valve. And then we also have your infectious endocarditis, usually caused by your Streptococcus viridans, often Staph aureus in IVD user. So take note of the hat check. But in some occasion, it can be due to fungi, rickettsia, or chlamydia. It can be acute or subacute. Take note the vegetations. In general, the vegetations is a umbrella term. You can see that in RHD. So the vegetation RHD are smaller. In infected endocarditis, the vegetation is very bulky. In non-bacterial thrombotic endocarditis or marantic endocarditis, it's very similar to your RHD, but they are bigger. While in Liebman-Stack endocarditis, usually from SLE, the vegetation are present both in both sides of the valves. So in the first three, the vegetations are only present at the line of closure. In in Liban sac endocarditis, the vegetation are present both in the inside and outside of the valve. These are some of the morphologic systemic changes in infective endocarditis due to the embolizations of your vegetations to different parts of the body. It can cause some of the petechiae-like signs in the finger here, in the toes, and even in your ophthalmologic examinations. So this is an infective endocarditis, very bulky vegetations at the line of closure of the valves. So it is due to bacteria, but you have also to test for fungi and AFB to rule out fungal or tuberculous vegetations. So we say a non-infected vegetation when all the bug stains are negative, negative for bacteria, fungi, or acid-fast bacilli. This is usually secondary to atrocious syndrome, which is defined as migratory thrombophlebitis with malignancies, or also in patients with cancers in the colon, pancreas, etc. So this is in comparison with infective endocarditis. So in IE, the vegetations are bigger, while in marantic or non-bacterial thrombotic endocarditis are much smaller, but bigger compared to your rheumatic heart disease. Now this is the Liban sac endocarditis, which is where the vegetation are present both in the line of closure and also on the inside, both in the outside and the inside of your valve. Let's go to the carcinoid syndrome, characterized by episodic skin flushing, cramps, nausea, and vomiting. In some books, this is also termed as carcinoid valvulopathy, but in the book, in Robbins, simply termed as carcinoid syndrome. So there is a fibrous intimal thickening, usually of your tricuspid valve, but can also be from pulmonic valves. So if you cut through it, you could see a very thickened layer of your valves. So this is like a hyperplastic tricuspid or pulmonic valves. What about the artificial valves? So in some center, they use a porcine valves, which can be organic, or in some places they use metallic components. So in general, the complication of the valves occurs within 10 years. So we have, depending on the condition of the patients, the valve has to be replaced every 10 years. So another question here is, how do you sample an artificial valve? You simply collect the areas here. If you can see some soft tissues like maybe vegetations or thrombus, and that is submitted. And then you just document by photo maybe the type of valves submitted. And then we have the myopathic valves, and these are already the cardiomyopathies. So we have the dilated, hypertrophic, and restrictive. If we have to be to summarize this portion of the lecture, so you have a normal here. The dilated is, of course, extreme dilatation of the LV. It is said that the valve can only dilate a certain portion, but an exaggerated dilatation you have to suspect for a dilated cardiomyopathy. A hypertrophic cardiomyopathy, so the heart on the outside looks normal, but if you cut through it, you can see a very thick wall, especially in the LV, and of course the weight will show you or will give you an idea that you are dealing with hypertrophic cardiomyopathy. In restrictive cardiomyopathy, basically these look like normal heart until you examine your sample, and you can see some amyloidosis infiltrations and other ground substances that can cause this restriction. So these are a table which is very important. So in dilated, among the important etiologies, the alcohol, possible adriamycin, sarcoidosis, hypertrophic. It can be from genetics. So from athletes, usually very athletic person suddenly died of arrhythmia, or you have a diagnosis of sudden cardiac death, and then you see hypertrophic cardiomyopathy, the Friedreich ataxia, storage diseases, and other conditions. Restrictive can be idiopathic amyloidosis or radiation induced. So again, in dilated cardiomyopathy, there's a chamber thickness actually of all, not just of LVH, but all chambers, causing a progressive declining of your left ventricular ejection fraction. So it correlates with the prognosis. 50% die in 2 years. The main cause is alcohol. So there's a four-chamber dilatations, and the microscopic examination which shows a lot of interstitial fibrosis here. This is a special type of your dilated cardiomyopathy called the arrhythmogenic right ventricular cardiomyopathy. So the heart is dilated, but instead, if we examine at the microscope, the heart is replaced by fatty tissue. So this is an uncommon dilated cardiomyopathy, predominantly at the right ventricles. Then we have the hypertrophic cardiomyopathy. Um, there's a genetic defects involved here with beta myosin heavy chain, changes in the troponin alpha, tropomyosin, myosin binding C, which will be discussed by Dr. Tan in the coming webinar. So this is one again of the exaggerated hypertrophy of the heart. There's an asymmetric septum, disarray of myocyte, and interstitial fibrosis, which is also seen in your microscope. So there's a disarray and a lot of interstitial fibrosis. So in general, the microscopic examination is not a very good assay or test to differentiate dilated and hypertrophic, because these are mostly morphologic diagnosis. And then we have our restrictive cardiomyopathy. So you have a normal chamber size and wall thickness, but if you examine the specimen, you can see some infiltrations like amyloidosis, or radiation changes as well. So the representation of your hypertrophic cardiomyopathy is your amyloidosis. So from Congo red, you can see here. So in our center about 19 years ago, we have, this was similar. This was 19 years ago, similar case. Primary systemic amyloidosis in a 52-year-old male. So fortunately, your amyloidosis of the heart can present with specific findings in your 2D echo. So it was easier to diagnose, especially if you have a high index of suspicion. Another type of cardiomyopathy is your Takotsubo cardiomyopathy. So this is not yet classified whether this is a hypertrophic, dilated, or restrictive. But this is an acute cardiac syndrome because this is reversible as well. So this is an acute cardiac syndrome which presents like acute coronary syndrome. So there's a typical left ventricular ballooning in the absence of coronary artery stenosis. So that criteria is very important. There should be an absence of coronary artery stenosis. This is also called your broken heart syndrome, precipitated by acute emotional or physical stress. So you can see the progression here. So Takotsubo is like a octopus trap in Japanese. So again, showing you the progression, the enlargement of the ventricles. Now the cause of this is due to catecholamine surge from heavy emotions. So catecholamines can cause direct myocyte injury. It can cause coronary vasospasm, coronary endothelial dysfunctions, neuronal dysfunctions, all would lead to the Takotsubo cardiomyopathy. And then we have your myocarditis, or the inflammation of myocardium, which can be due to the following organisms. Now take note, in myocarditis, even few lymphocytes present, or in case of acute neutrophils, these are already significant because in general, the heart should not contain any inflammatory cells. And the danger of your myocarditis is it can cause arrhythmia, and they can also be fatal. And then we have your pericardium, normally about 30 to 50 ml of clear serous fluid. We see a lot of pericardial effusions in our center because of tamponade. It can be due to ruptured MI, traumatic perforation, or even aortic dissections. How about pericarditis? We have serous, fibrinous, purulent, hemorrhagic, caseous, or chronic as well, depending on the etiology. So this is what we call the bread and butter pericarditis from rheumatic heart disease. So this is like putting a spread into slices of bread, and then you open it up, and you can see here the bread and butter pericarditis. Tumors, so we know very well about this. We have myxoma. The left atrium is the most common, but from the census, you can also see fibromas, lipomas, fibroelastomas, and of course, rhabdomyoma, which is most common cardiac tumor in children. But the malignancy that we see are mostly sarcomas, which are similar to your soft tissues. So you can see angiosarcoma, leiomyosarcoma, rhabdomyosarcoma, synovial sarcoma. So here, now the significant of myxoma is that this is a very fragile tumor, so they can be dislodged and can cause embolization to other parts of the body. So I won't discuss extensively. So you can hear the myxoma cells here, which is like spider-like cells in a myxoid background with some inflammations, some hemorrhage, or hemosiderophages as well. Your papillary fibroelastoma, you can see this. If you submerge this in water, it would resemble like your sea anemones, but that papillary structure is seen here because of these configurations. And then rhabdomyoma, the most common benign tumor in children. So in microscope, you can see here the spider cells. And this is associated with your tuberous sclerosis. And again, the most common malignant tumors in adult is your angiosarcoma. So usually, if it is on the right side, there's a big chance that this is a malignancy. So the histologic features of your angiosarcoma is similar to what you can see in the soft tissue. And then you have the cardiac effects of non-cardiac tumors. So it can have direct consequence of the tumor. So if it is malignant, it can cause metastasis. If it's benign, it can cause emboli. Indirect consequence can cause endocarditis, myeloma, associated amyloidosis. And of course, if you treat this with chemotherapy or radiations, it can also affect your heart. So the cardiac transplant, we don't do it here so far at this point, but I think in the 80s this was done in Makati Medical Center. But the survival in general is still about more than 60%, depending on the center where it is being done. So it is important to monitor whether the transplanted heart is not undergoing any rejection. So this is an example of your biopsy of the heart. So the transplanted heart shows a lot of lymphocytes, so there is a rejection present. Now let's go to the pathology of the blood vessels. So very short discussion. So just to show you the vasculitis, depending on the size, we have large vessel, Takayasu or giant cell, the medium size, your polyarteritis nodosa and Kawasaki. And then you have your immune complex, small vessel vasculitis, and your ANCA associated small vessel vasculitis. So in general, the diagnosis of the vasculitis relies heavily on the clinical symptoms. So what is probably important here is how to submit, or really to emphasize that one of the emergency or critical specimen in anatomic pathology is a temporal artery. So when you receive a temporal artery, it is important to submit it as soon as possible, because you can, if it is a a diagnosed temporal arteritis, you can save the patient, or the patient rather, from going blind, because the patient can be treated with steroids if the diagnosis can be done as soon as possible. So this is from the Royal College of Pathologists of Australia. In general, they want to submit the entire temporal artery biopsy and embed it uh, in a, in a in this sequence to really see the part of the inflammations. But of course, this is always associated with the clinical presentation of the patient. Now, recently they use, which we are also applied now. This was submitted or published only in 2017, the consensus on the surgical pathology of the aorta. So we have grading here, let's say for the segments of aorta. So we grade them as mild, moderate, severe based on the histology. But currently, uh, um, the significance, or rather the criteria, is simply based on the histology here. But like for me personally, I just give a rough diagnosis based on the extent of the atherosclerosis present, rather than I follow this histology. So this is just recommendation, showing here the different grading of your aorta. And of course, you have also the different stain here. You can do the elastic fiber, the smooth muscles for the trichrome, laminar collapse, and the extent of your medial degenerations, saying it's mild, moderate, or severe. So you can apply this, but in other center, I don't think they are using this criteria. So you can see here, extensive loss of your elastic fibers in some of the aneurysmal vessel wall. Now, last of the topic is the pathological features of COVID-19 associated myocardial injury. This is published on April 2020. So these are the spectrum of myocarditis we can see in this patient. So some of those changes are the presence of myocarditis in COVID-19. Other changes are increased interstitial macrophages here. This is from a certain number of autopsy. Other myocardial inflammatory changes in autopsy are focal lymphocytic pericarditis. They also see some sort of healing myocardial injury in the myocardium. Other changes are right ventricular myocardial injury consistent with strain here. Also, they have damage in the small vessel, myocardial damage, and organizing microthrombi. So to summarize, these are the changes, or the cardiac changes in COVID-19. The most common is the diffuse macrophage infiltration, about 86%, followed by your small vessel thrombi, and also your focal pericarditis and RV strain, and also the less common are the lymphocytic myocarditis and endocardial thrombosis. So if you're more interested in cardiovascular pathology, you can also visit this website by Dr. Carmela Tan and Dr. Rene Rodriguez, eheart.org. That's all. Thank you.